Good afternoon and welcome. My name is Susan Latham and I'm a faculty member in the Master of Autism Studies program. And I have the pleasure today to introduce our speaker, Dr. Michael Waddell, and our respondents, Dr. Joshua Diehl and Carter Snead. So Dr. Michael Waddell holds the Edna and George McMahon Aquinas Chair in Philosophy at St. Mary's College. He is the director of the Master of Autism Studies program, and he is the reason why we're all here today. Without Dr. Waddell, we would not have a Master of Autism Studies program. So his commitment to the program and to the autism community is unwavering, and we are all profoundly grateful. He will present his paper titled Autism and Assisted Suicide, What's Happening in Europe and Why It Should Stop. We'll have two respondents. The first, Joshua Diehl. He is a clinical psychologist recognized as a leading expert in autism. He is the Chief Program Officer for Child and Adolescent Services at Logan Community Resources, and he serves as the Associate Editor for the Journal of Autism and Developmental Disorders, and he also is a Faculty Fellow in the Master of Autism Studies program. Our second respondent is Carter Snead, and he is an internationally recognized expert in the field of bioethics, including end-of-life issues. He is Professor of Law at the University of Notre Dame Law School, and he is the William P. and Hazel B. White Director of the Center for Ethics and Culture at Notre Dame. Prior to joining the law faculty at Notre Dame, he served as General Legal Counsel to the President's Council on Bioethics, and he is an elected Fellow of the Hastings Centers, which is the oldest independent bioethics research institute in the world. And in 2016, he was appointed by Pope Francis as a member of the Pontifical Academy for Life, and that is the principal bioethics advisory board to the Pope. So welcome.
Thank you, Susan. Those of you who know me know that I'm prone to go off on tangents, and so I'm going to stay very close to the script today. The laughter is sincere. I'm going to stay very close to the script today so that I can stay on time. Just a quick note before I begin reading my paper. Throughout the paper, and in fact in conversation, I often use what's called identity first language, or language of the form autistic person, rather than what's called person first language, or language of the form person with autism. In the autism community, as in the deaf community and the blind community, identity first language is the preferred form of usage of many self-advocates. And so I choose that usage in no small part out of respect for their preferences. But please know, though, that my choice of language is not in any way intended to diminish or disrespect the personhood of people on the spectrum. It's now well documented, if not so well publicized, that autistic people have died by euthanasia and assisted suicide in Belgium and the Netherlands. In a recent study of assisted suicide involving individuals with intellectual disability and autism in the Netherlands, Irene Tufrivena and her colleagues have presented 3 case reports from the Dutch Regional Euthanasia Review Committees, or RTEs as they're called, that describe individuals with diagnoses of autism who died by assisted suicide between 2012 and 2016. I have found another RTE case from 2017 involving a woman diagnosed with pervasive developmental disorder not otherwise specified, which is of course also an autism spectrum disorder. In a study of the databases of the Belgian Federal Control and Evaluation Committee on Euthanasia, Dierix et al. Examined cases of psychiatric disorders and dementia between 2002 and 2013 and found 7 cases in which individuals diagnosed with autism died by euthanasia during that period. And in a study of 100 patients who presented consecutively at her psychiatric clinic in Belgium between 2007 and 2011, Liv Tienpont reported that 7 patients had diagnoses of Asperger's syndrome, which is another autism spectrum disorder, when they arrived at her clinic. She referred 13 more patients for further testing for autism, and 12 of them received diagnoses of Asperger's syndrome. So 19 of Tienpont's 100 patients ultimately had diagnoses of autism. In email correspondence with Dr. Tienpont, I've learned that 10 of these patients' requests for euthanasia were approved, and of these 10, 8 ultimately died by euthanasia, 2 from the initial group of 7 who arrived with diagnoses of autism, and 6 from the group of 12 who were referred for further testing. Note, therefore, that 75% of these people were not diagnosed with autism until after they arrived at Dr. Teenbot's clinic, which was often within just a few months of their deaths by euthanasia. We'll come back to this later. As many of you probably know, euthanasia and assisted suicide, or EAS for short, is legal in a number of countries, including Belgium, the Netherlands, Luxembourg, Switzerland, Colombia, and Canada, as well as in a number of jurisdictions in the United States, including Oregon, Washington, California, Colorado, Montana, Vermont, Hawaii, and Washington, D.C. At present, most of the jurisdictions that have legalized EAS do not permit it for individuals whose suffering is caused by non-terminal conditions, including psychiatric and psychological disorders. However, both the Belgian Act on Euthanasia of May 28, 2002, and the Netherlands Termination of Life on Request and Assisted Suicide Act of 2002 allow EAS for patients suffering from psychiatric or psychological disorders when certain due care criteria are met. While the conditions laid down in these two acts are not identical, there are nonetheless certain common criteria that must be met for EAS to be legal in both jurisdictions. First, individuals seeking EAS must be legally competent. That is, they must have the capacity to make this particular decision. Second, they must make a request that is voluntary and well considered. And third, the individual must be suffering unbearably from a condition that is medically futile, such that there is no reasonable alternative to EAS for alleviating the person's suffering. These due care criteria have been put in place by the Belgians and the Dutch to protect vulnerable individuals from the irremediable harm of premature death. If any of the criteria are not met, then administering EAS becomes ethically and legally problematic on the Dutch and Belgians' own terms. The practice of granting EAS for psychological or psychiatric disorders in general has drawn a fair bit of public scrutiny, but there are complex issues specific to autism that have received very little attention in the literature. Prescinding from the questions of whether euthanasia and assisted suicide are immoral acts in their own right, or whether psychiatric and psychological disorders as such should be grounds for EAS, I would propose that even according to the requirements of the due care criteria that have been established for EAS in jurisdictions that have legalized it solely for psychiatric reasons, there are serious concerns to be raised about the ethics and perhaps even the legality of ending the lives of autistic people by EAS. In particular, I think there are important questions that need to be asked about the due care criteria noted above as they relate to autism. First, how might autism affect decision-making capacity for EAS? Second, how might autism affect the voluntariness of an EAS request? And third, is autism indeed a medically futile condition such that there is no reasonable alternative to EAS for alleviating suffering? Until these questions are answered, I would suggest that it might be prudent to think of autistic people as a vulnerable group at heightened risk of premature death and thus irremediable harm from EAS. Let's begin by considering legal competence and decision-making capacity. We know relatively little about the decision-making of people on the spectrum, and even less about their capacity to make decisions specifically about EAS. In fact, I'm not aware of a single study that examines this specific dimension of autistic decision-making directly. That fact alone should give us pause, since EAS is a grave act that cannot be undone. More problematically, though, the things that we do know about autistic people's decision-making in general should raise concerns about their decision-making capacity for EAS in particular. Luke et al. State that the collective evidence of the few studies that have been done on decision-making in people with autism suggests that the decision-making of adults with autism spectrum disorders may differ from that of the neurotypical population, that their tendency to rely on rules might interfere with autistic people's making decisions, that stigma also appears to influence their decision-making, that adults with autism more often perceive their condition as interfering with rather than enhancing decision-making, and that as scores for anxiety and depression increase for these individuals, the perceived frequency of interference from autism also increased. This last point is particularly important since anxiety and especially depression are risk factors for suicidality in people on the spectrum. So if increases in anxiety and depression also lead to greater interference with decision making, there might be a kind of perfect storm brewing for autistic people experiencing co-occurring anxiety or depression while making decisions about EAS. All of this leads Luke et al. To conclude that their own findings suggest that, quote, compared with neurotypical individuals, intellectually able people with autism experience greater difficulty with decision-making, end quote. Of course, the mere fact that autistic people might make decisions differently, or even have difficulty making decisions, doesn't necessarily mean that they don't have the capacity to make this particular decision. How then can we begin to tackle the question of whether autism might affect decision-making capacity in EAS cases? The most widely accepted standards for assessing decision-making capacity are the Applebaum criteria, which include the abilities to communicate a choice, to understand relevant information, to appreciate the medical consequences of the situation, and to reason about treatment choices. It's been observed, though, that these criteria are primarily cognitive, and various scholars have suggested that they're not sufficient to capture everything involved in decision-making capacity. According to Eckstein and Kim, quote, a person may be able to comprehend and believe that a harm would in fact occur to him or her without the treatment, but that doesn't automatically translate into a decision to accept the treatment. The person's ability to incorporate one's motives or values into the decision must also be intact. This ability is distinct from the ability to form adequate beliefs or appreciation. If for some reason the person is incapable of being motivated to avoid the harm at issue, then he or she may not have decision-making capacity, end quote. Now, some scholars have also argued for a more important role of emotions in decision-making capacity. For example, Klug proposes that decision-making capacity has three necessary components, namely cognitive, valuational, and emotional competence. And Charlin presents a compelling integrated model of decision-making capacity in which emotions give rise to values, and values drive appreciation, which is one of the cognitive dimensions of decision-making. As it turns out, studies have shown that people with autism exhibit differences and often impairments in all three areas of decision-making capacity: the cognitive, the valuational, and the emotional. People with autism, especially so-called high-functioning autism, often have or appear to have intact cognitive capacities, that is, capacities for logical or analytic thinking. But DSM-5 indicates that the intellectual profiles of people with autism are complicated, with uneven abilities and gaps between measured IQ and adaptive skills often observed. And studies have produced evidence of impairments in autistic people across a wide range of cognitive domains that affect decision-making, including adaptive function, executive function, such as planning, mental flexibility, working memory, and some types of inhibition, and the ability to learn which decisions are advantageous and which are disadvantageous. Interestingly, Levin et al. Concluded that, quote, decisions that normally rely on affect or intuition might be more difficult for individuals with autism to make than decisions that rely on deliberative and logical thinking, end quote. Zhang et al. Found that autistic subjects had impairments in decision-making under ambiguity and under risk, and suggested that poor decision-making in autistic subjects might correlate with impairment in emotional processing of feedback in terms of gains and losses. Thus, both Levin and Zhang suggest that deficits in decision-making among people with autism might be related to difficulties with affect or emotion. Consistent with these suggestions, there's evidence that people with autism process emotions differently from neurotypicals. In particular, there have been a number of studies that have found emotional dysregulation in people on the spectrum. For example, Ritchie et al. Found decreased brain capacities for upregulating and downregulating emotion in autistic subjects compared to their control group. Nuski et al. Note that children with autism are at a much higher risk for emotional regulation problems than typically developing peers, and that difficulty regulating negative emotions in individuals with autism has been found to impact their behavioral and mental health. And Thompson et al. report a relationship between emotional regulation problems in children with autism and depression. Once again, the connection between emotional regulation and depression is especially important here because, as noted above, depression has been linked to increased suicidality for people on the spectrum. Given the relationship between emotions and valuing, and given common differences in the emotion processing profiles of people on the spectrum, it's not surprising that studies have also identified differences between autistic people and neurotypicals in various dimensions of valuation. Spickens et al. Found that individuals with high autism spectrum questionnaire scores tended to value objects that have practical function, such as laptops, more highly than objects that have sentimental value or reminders of relationships, such as pictures of loved ones, whereas neurotypical subjects were more likely to value objects with purely sentimental value. Wang et al. Found that children with autism perform just as well as typically developing controls on non-social value learning tasks, such as valuing objects rather than people, but performed less well on social value learning tasks, such as the ability to select faces or the most relevant parts of faces. At a more neurological level, Coles et al. Found reduced activation of reward centers of the brain when autistic subjects were exposed to both social and monetary rewards, and Dichter et al. Found reduced activation of reward centers of the brain when autistic subjects were exposed to monetary rewards, but not when they're exposed to autism-related objects, such as electronic devices or trains. Together, these studies suggest differences in valuing between autistic and neurotypical people. Of course, differences are not always deficits, but we must nevertheless ask whether in some instances these differences might compromise valuational capacities. To tie this all together, while we still know relatively little about autistic decision-making as it pertains to EAS specifically, the collective evidence of studies of autism and decision-making in general gives cause for concern. If decision-making capacity has cognitive, valuational, and emotional components, and if individuals with autism often manifest differences and even impairments in all of these domains, we must consider the possibility that impairments in these dimensions of decision-making might affect the EAS requests of autistic people. What is more, the case files of the Dutch euthanasia committees give evidence that these are not just speculative concerns. Of the 4 RTE cases involving people with autism spectrum disorders, 3 report symptoms that suggest problems with emotional regulation, and all 4 report symptoms that suggest problems with executive function. And yet, the case files contain no explicit consideration of whether or how these factors might impact decision-making capacity for these individuals. Nor is there evidence that experts in autism who might better understand the complex cognitive, valuational, and emotional profiles of people on the spectrum and recognize their possible implications for decision-making capacity have been consulted in these cases. And this despite the fact that this kind of consultation is recommended by the Dutch RTE Code of Practice. This raises serious questions about whether or to what extent the due care criteria for assessing decision-making capacity are really being met in these cases. Now, to be clear, I do not mean to suggest that merely having a diagnosis of autism renders an individual incompetent for decision-making in this area. Each individual must be assessed functionally for decision-making capacity and not simply on the basis of her diagnosis. But given what we know about differences and in some cases deficits in how people with autism cognize, value, and experience emotion, as well as how much we do not know about how people with autism function in these areas, I do want to suggest that every EAS request from a person with autism should, at minimum, be scrutinized very carefully for decision-making capacity with special attention to the cognitive, valuational, and emotional complexities of autism. And yet, despite the fact that reports from both Belgium and the Netherlands often acknowledge the need to proceed with great caution in cases involving either mental illness or intellectual disability, I see little evidence of this heightened level of caution or attention to the nuances of autism in either the case reports or the scholarly studies of cases involving individuals on the spectrum. A second requirement for EAS requests that's common across jurisdictions is the condition that the request must be voluntary and well considered. It's widely acknowledged that EAS requests involving depression need to be scrutinized very carefully because the request for death might be a symptom of the disorder. I take it that the fundamental problem in these cases is that the individual is not making a voluntary request. That is, she is not freely requesting death, but is rather caused to desire death by the disorder itself, which is in some sense extrinsic to her free will. And while the distinction might be a subtle one, this is different from making a free request to die in response to the suffering caused by a disorder, whether that disorder be physical or psychological. Now, I would propose that we need to consider the possibility that autism could put people at greater risk for psychological forces that would compromise the voluntariness of an EAS request. Stewart et al. State that diagnosis of depression co-occurring with autism can be difficult because there are shared core symptoms, such as social withdrawal, because barriers to communication might mask symptoms and make assessment more difficult, because onset of depression can manifest as an increase in symptoms of autism, such as obsessionality and self-injury, and because the characteristics of autism can affect the expression of depressive symptoms, as for example, in the case of the autistic man who became incontinent with urine when depressed, or another who lost bowel and bladder control when depressed, or others who become more aggressive or self-injurious during episodes of depression. In some cases, Stewart et al. Note, depression might even present as an improvement in autistic behaviors, such as in instances where a depressed individual becomes less interested in restricted interests or repetitive behaviors. Given the difficulty of diagnosing depression in autistic people, and given that depression often causes suicidality, there's reason to be concerned that people on the spectrum might be at heightened risk for requesting EAS because of undiagnosed depression rather than from a fully voluntary choice. Despite the difficulty of diagnosing depression co-occurring with autism, though, numerous studies have indeed identified a high co-occurrence of autism and depression. In fact, studies have suggested that anywhere from 30% to more than 50% of people with autism experience co-occurring depression during their lifetimes. For sake of comparison, a 2017 meta-analysis of data from studies of depression from 30 countries suggested a lifetime prevalence of 10.8% for the general population. So we're talking somewhere in the magnitude of 3 to 5 times higher rate of depression for autistic people. Interestingly, it's also been found that autistic individuals with less social and communication impairment and higher cognitive abilities are at greater risk for depression. Barnhart et al. Report that, quote, Atwood hypothesized that for adolescents with Asperger's syndrome, awareness of their social difficulties may lead to anxiety, confusion, and despair, end quote. We should note here that by definition, autistic people who can legally request EAS must be higher functioning and are therefore at higher risk for depression. Of course, for purposes of this paper, depression is important primarily because the disorder itself can cause suicidality, which can diminish the voluntariness of a request for death. As recently as 2013, Mays et al. Observed that, quote, although depression is common in autism, almost no research is available on suicide ideation and attempts, end quote. However, we have learned some things about autism and suicidality in the last few years. People on the spectrum present with much higher levels of suicidal ideation than does the general population. In a study of suicidality in people with Asperger's syndrome, Cassidy et al. Found that the lifetime experience of suicidal ideation was 66%, which they report to be 9 times higher than the general population in England. In a study of Swedish medical records, Hervikoski et al. Found that autistic people were 7.55 times more likely to die by suicide than the general population. In fact, suicide accounts for 14% of deaths in autistic adults who do not have intellectual disability. According to Hervikoski, females with autism are 13 times more likely to die by suicide than females in the control group. Moses et al. Found that youths with autism were 6 times more likely to report having made at least one suicide attempt in the last 12 months than youths without disabilities. Mays et al. Report that children with autism were 28 times more likely to have suicidal ideation or attempts than typically developing children, according to reports by their mothers. They also found that teasing was one of the comorbid psychological problems most highly associated with suicidality, with suicidal ideation or attempts being 3 times more common in children with autism who were teased than in those who were not. Headley et al. Found that autism traits correlate with loneliness and proposed a discrete mechanism in which loneliness, mediated by depression, contributes to thoughts of self-harm in adults with autism. Finally, Mays et al. Found that suicidal ideation correlated with anxiety in children on the spectrum, and that depression, unsurprisingly, was, quote, the strongest single predictor of suicide ideation or attempts in children with autism, end quote. It's interesting to note, though, that while individuals with autism and depression have very high rates of suicidality, many autistic people who do not have depression also report suicidal ideation and attempts. In fact, Cassidy et al. Found that the lifetime rates of suicidal ideation, 66%, were more than double the lifetime rates of depression, 31%, among their subjects with Asperger's syndrome, which led them to speculate that their data might suggest a different process for suicidal ideation in Asperger's syndrome than in other clinical groups. Cassidy et al. Also speculated that the late diagnosis of Asperger's syndrome in their cohort, the mean age of diagnosis was 31 years, speculated that the late diagnosis of Asperger's syndrome in their cohort might have contributed to high rates of suicidal ideation, noting that many of these individuals had difficulties such as social exclusion, unfulfilled educational potential, difficulties with getting or keeping a job or being promoted, and difficulties with developing close relationships, which could have been exacerbated through lack of appropriate support throughout their lives. And they concluded by suggesting that, quote, delayed diagnosis in adulthood could possibly be another risk factor for suicidal ideation and plans or attempts in people with Asperger's syndrome, end quote. Remember that 12 of Teen Pond's patients did not even receive their autism diagnoses until she referred them for further testing as part of the EAS request process. And 6 of those 12 ultimately died by euthanasia. In light of Cassidy et al.'s suggestion that late diagnosis of autism might be a risk for suicidality, it's worth asking whether these individuals might have been at elevated risk for suicidality because of their late autism diagnoses, and might therefore have been especially vulnerable to possible harm from euthanasia, even relative to other people on the spectrum. Given the findings that people with autism are at significantly higher risk for depression and suicidality, it's entirely unsurprising that many researchers recommend screening children, adolescents, and adults on the spectrum for both depression and suicidality. To be sure, we need much more study of suicidal ideation and attempts in the lives of people with autism. But if depression and suicidality can limit the voluntariness of a request for death, what are the implications of the difficulties of diagnosing depression co-occurring with autism? More disconcertingly, what are the implications of the very high levels of depression and suicidality already known to exist among people with autism? Mustn't we at least consider the possibility that depression could easily be going undiagnosed in people on the spectrum who request EAS, and that there is a heightened risk for the voluntariness of EAS requests from autistic people to be compromised by depression and suicidality? Once again, these are not merely speculative concerns. In the 4 Dutch RTE case files involving patients with autism, one person is described as having, quote, severe and probably chronic depression. One is described as suffering from, quote, continuous and suicidal thoughts. And one is described as having made multiple suicide attempts from an early age. Yet the case files provide no evidence of serious consideration of the possibility that the voluntariness of these requests might have been compromised. Instead, each simply states, using boilerplate language, that, quote, a voluntary and well-considered request was made. Sometimes within just a few lines of noting the patient's depression or autism. Finally, let me turn to the question of whether the condition of autistic people is medically futile or incurable, such that there is no prospect of improvement and no reasonable alternative to EAS for alleviating their suffering. Since it is true that autism is not generally regarded as curable, I'll focus on the issue of whether there is no reasonable alternative to EAS for alleviating the suffering of autistic people. To the best of my knowledge, there is no systematic study of either the qualities or the severity of suffering that people on the spectrum experience from their autism. In the Dutch RTE case files, though, we find one report of physical suffering as a result of sensory hypersensitivity. 3 case files report suffering arising from problems with emotional regulation, and all 4 case files report suffering arising from problems with executive function. The most striking feature of the accounts of suffering in the Dutch case files, though, are reports of suffering that we might describe as social, interpersonal, or relational. For example, in case 2017-80, by the way, I am not wild about the overtones of attaching numbers to these people as we're ushering them through a process leading to death. But that's the system. In case 2017-80, we read that a young woman with PDD-NOS, quote, could not enter into friendships and had become isolated, even within her own family, end quote. In case 2016-48, we are told that an elderly woman with autism, quote, no longer had any interest in the world around her and was no longer able to form social contact. She was avoidant of care and contact. The patient spent her days in isolation in her room, end quote. In case 2013-21, we read that an older gentleman who was self-diagnosed with Asperger's was, quote, an utterly lonely man. He quarreled with everyone who wasn't a support professional. The patient had become totally stuck in isolation and found this increasingly painful. And in case 2014-77, we are told that a younger man with Asperger's syndrome, quote, suffered from the fact that he had a great need for closeness with others, whilst he couldn't maintain long-lasting social contacts. He suffered from his continuous yearning for meaningful relationships and his repeated frustrations in this area because of his inability to deal adequately with closeness and social contacts. These accounts of social suffering are heartbreaking, but not entirely surprising. Impairments in social interactions and social communication are at the core of autism. And studies show that people on the spectrum are at risk for loneliness and isolation, which are predictors of depression and suicidality. So small wonder that loneliness and isolation should feature prominently in the suffering of autistic people seeking to die. The social suffering of people on the spectrum is, of course, complex. It can arise to some extent from deficits in social communication and social interactions in autistic people themselves. It can also be caused directly by other people, as in instances of bullying and teasing, which are common for people on the spectrum and are predictors of both depression and suicidality. Whatever its causes, though, it is clear that the social suffering of people on the spectrum can be profound enough to make some wish for death. Without wanting to diminish the significance of the impairments or the very real challenges autistic people have in forming satisfying relationships, it seems to me that this is a situation that cries out for analysis in terms of the social model of disability. As many of you probably know, the social model of disability suggests that disabilities do not arise primarily from biological or psychological impairments, so much as from disabling conditions created by society. Now, I do not think the social model is adequate to explain the full range of disabilities. But in the case at hand, I think it has something very important to offer. After all, relationships are, by nature, two-way streets. And at least some of the difficulties autistic people experience in forming relationships result from the ways in which neurotypical people respond to autistic people. So the suffering caused by these difficulties can also be affected by altering the way neurotypicals relate to autistic people. For example, if we could just eliminate bullying and teasing, if we could develop understanding and acceptance of social and communicative differences, and if we could foster inclusion and friendships between neurotypical people and people on the spectrum, these simple actions could fundamentally alter the social disability and suffering of many autistic people. In the extreme cases we encounter in euthanasia and assisted suicide records, they might even be life-saving measures. These are not, by the way, just the musings of a philosopher. We find similar recommendations coming from the scientific community. For example, Headley et al. Concluded that, quote, the identification of loneliness as a factor associated with depression and thoughts of self-harm as a screener for suicidal ideation in this study points to potentially useful treatment options. Programs that combat loneliness or promote inclusion may provide benefits in terms of mental health and well-being, end quote. Indeed, in some cases, they might be the difference between life and death. Beyond this, though, it's important to note that there is less reason every day to despair that autism is a futile condition such that there's no reasonable alternative to EAS for alleviating patients' suffering. The number of evidence-based interventions that can effectively address the core impairments of autism has grown steadily over the past few decades. And there are interventions that specifically address problems that recur thematically in the accounts of suffering of autistic EAS patients, including programs for improving emotional regulation and executive function, such as planning, problem solving, and flexibility. What's more, while we once tended to think that autism interventions were effective for only a brief developmental window during childhood, there's now evidence that interventions can be effective into adolescence and even into adulthood. Crucially, there are now evidence-based interventions for adults on the spectrum that target social skills and the symptoms of anxiety and depression. This would include, for example, the Peers Method. We hosted a 3-day seminar on the Peers Method last spring. In fact, there is now evidence that interventions that develop social skills with people on the spectrum might themselves ameliorate symptoms of depression and suicidality. These interventions offer new hope of overcoming the devastating isolation and loneliness that are so prominent in the suffering of autistic people who request EAS. Now, inasmuch as the due care criteria require that the patient's condition be medically futile, such that there is no prospect of improvement and no reasonable alternative to EAS for alleviating her suffering, we must ask whether these autism interventions have really been given a fair trial. Unfortunately, the answers we get from both the Dutch case files and the Belgian reports are not reassuring. Only one of the 4 Dutch RTE case reports even mentions autism interventions, and it does so only vaguely. And in Dr. Tienpant's Belgian studies, we find that there are individuals not being diagnosed with autism until they are well into the euthanasia process, sometimes just a few months before their deaths. Since most autism interventions require months or even years to be effective, one wonders whether it's even possible that these interventions could have been tried in any serious way, and thus whether the due care criterion that there be no reasonable alternative to EAS for alleviating the patient's suffering was really observed. To conclude then, there's a great deal we don't know about autism and EAS, but there are some things we do know. And those things raise questions about whether the due care criteria are being strictly observed in cases dealing with autistic people. First, we know that the cognitive, emotional, and valuational impairments can affect decision-making capacity. We know that people on the spectrum commonly exhibit impairments in all of these areas. And we know that the Dutch RTE files provide evidence that actual autistic people whose lives have been ended by EAS exhibited traits that appeared to reflect impairments in these areas. Second, we know that depression and especially suicidality can diminish the voluntariness with which a request for death is made. We know that people with autism are at severe risk for both depression and suicidality. And we know that autistic people whose lives have been ended by EAS exhibited symptoms of both depression and suicidality. Finally, we also know that while autism can sometimes cause tremendous suffering in the lives of people on the spectrum, there are interventions that can address the symptoms that cause many kinds of their suffering. And in fact, something as simple as the way that neurotypicals respond to autistic people can be a powerful means of alleviating one of the most profound types of suffering that autistic people experience: loneliness and isolation. But the Dutch case files give very little evidence that these interventions are being employed. And the Belgian studies raise doubts about whether it's even possible that they could have been employed because of late diagnoses of autism and the time required for autism interventions to be effective. As noted above, the Dutch and Belgian due care criteria require that individuals requesting EAS have decision-making capacity, make a voluntary request, and suffer from a condition that's medically futile, such that there's no reasonable alternative to EAS for alleviating the patient's suffering. But the case files and scholarly studies provide startlingly little evidence that the nuances of autism are being taken into account in assessing these matters, which raises grave concerns about whether the due care criteria are being strictly observed in cases in which autistic people have in fact died by EAS. These due care criteria were put in place to protect vulnerable people from the irremediable harm of death, premature death. And we need to ask whether autistic people are especially vulnerable to this harm. This might sound paternalistic. It might even be paternalistic. But the stakes here could not be higher. And I think we owe it to autistic people and their loved ones to have a deeper, more transparent public discussion of these matters than we've had to date. Thank you. So now we'll transition to So I think we'll begin with Dr. Joshua John Diehl, and then Professor Carter Snead will follow.
Great. Hello, everybody. I just wanted to let you know that I will be using person-first language when I refer to individuals with autism, because the belief that we should use identity-first language is not held by all individuals with autism. In fact, there are some individuals with autism who agree with other people with other disabilities that it should be person-first language and not identity-first language. However, that will be a discussion for another talk someday. I wanted to first comment on, I've read through Dr. Waddell's paper, and now after hearing him talk, I just wanted to first say that I was, as a psychologist and somebody who's immersed in autism research, I was impressed with the depth and the accuracy of what he presented in terms of his research. And in addition to that, I wanted to highlight that depression in autism spectrum disorder is a major issue, and it's very hard to identify in individuals with autism. So all of these things that he brought forward as reasons for these, why we should consider the due care criteria are all valid, and I have no concerns with those that have been brought forward. I also wanted to say, if we're talking about the due care criteria, we're really talking about 3 criteria. And if I understand it correctly, only one of them needs to be met, and then it's
Not met.
yeah, right. So I think.
Wait, could you say that again?
Yeah. So it's my understanding of the law, and you may have more insight to the law than I do. In fact, you almost certainly have more insight to the law than I do. It's my understanding that if any of the due care criteria are not met, that sort of kicks into place a sort of process of heightened review.
Right.
That could include sending it along to a prosecutor.
Mhm.
Right.
And I think with that being considered, I think we're talking about being legally competent, being able to make the decision voluntarily, and having a medically futile condition are the 3. I think the third one, a medically futile condition, I think is a slam dunk when it comes to autism. I think there's no question that the research has shown that with appropriate supports and care, that people with autism can lead fulfilling and successful lives. And more we're learning that there are a plethora of interventions that we can use to help people with autism. So from the standpoint of autism within this framework, I think using autism as a diagnosis for which you could be eligible for this, I think is refuted by number 3. I think you wouldn't meet that criteria with autism. And I think that that's a pretty strong argument. What I wanted to focus on just for a moment is really number 1 and possibly number 2. The idea that individuals with autism may or may not be legally competent to make these decisions, and that they would be making these decisions voluntarily. Historically, in our culture and in other cultures, things related to cognitive deficits, disabilities, have been used to keep people with disabilities from going to school, in some cases from having children, having the ability to vote, own property, move through the community freely, and perhaps ironically, they've actually been used to make decisions on whether or not they should live, as was shown during the eugenics movement, where people with developmental disabilities were killed because they had developmental disabilities. So for me, I have a very sensitive red flag when it comes to denying people rights based on a diagnosis or a disability status. So when I was reading this, that was the thing that I was really sensitive to. I agree with the premise of the paper, but I just really wanted to make sure that there wasn't some sort of discrimination that was going on, especially as it relates to number 1. I think that focusing on number 1 or even number 2 could lead to discrimination. I know that Dr. Waddell made the important point that he wasn't focusing on saying that autism itself shouldn't be the reason that they couldn't get access to this legal right that they have to euthanasia. And that's what it is in Belgium. It's a legal right to have, in certain circumstances, to have this. But he said that there should be heightened scrutiny if you have this autism diagnosis. And my concern is that doesn't seem that far off to me from saying that somebody could be pulled over because of the color of their skin, that they are more likely to commit some sort of crime or be some sort of criminal. I don't think it's that far off. I'm not saying that the two are analogous, but I worry that with heightened scrutiny based on some sort of diagnostic category, that it could lead to discrimination. Let me give an example of where I would be concerned. An example of where I would be concerned if somebody had autism and they had another qualifying condition, not depression, but another qualifying condition in which it was terminal. I would be concerned that in this case, that even with one clear qualifying condition, that individual might be denied the right to be able to access euthanasia like other people, whether or not you agree with euthanasia. This is something that's been determined to be a legal right, that they might not be able to access that right because of having autism. So I think that that's tricky. And I think because addressing or assessing somebody's functional ability to make those decisions is difficult. It's acknowledged that that's difficult, that focusing on autism as something that would be of heightened scrutiny over whether or not that they would be legally competent to make these decisions, I think is problematic to me. I would also say that in the discussion about whether or not somebody with autism could make the decision voluntarily, having that discussion be about depression and autism, to me, doesn't actually feel as much like it's about autism as it is about depression. Ultimately, the issue is that individuals with autism might be more are more likely to have depression, especially with higher cognitive abilities. So I think the important piece of that is, again, not whether or not somebody has autism, but really the depression itself and the importance of understanding depression and the role it would play within these sorts of euthanasia decisions. But broadly speaking, I really think that the points, especially related to number 3, are right on. But I think as we're thinking this through, and as we're thinking this through from a legal standpoint, it's really important to be cognizant and sensitive to the fact that we are not denying people rights based on a diagnosis.
I'm going to invoke the privilege and sort of respond directly. I'll do my best to be brief, which again is not my strong suit. But let me sort of work back upstream, right? So let me start with your second observation, which is that when we focus on the issue of whether the decision is voluntary or not, and we're connecting it to depression, which I certainly am doing, the high co-occurrence of autism and depression is a critical concern for me. But I think we have to be careful not to go so far as to suggest that it's only depression, because we have that study from Cassidy that shows that the lifetime incidence of suicidality for people on the spectrum is actually significantly higher than the lifetime incidence of depression, 2 times higher, which to me raises the possibility that there may be some kind of a discrete mechanism connecting autism with suicidality. Now, I want to be very careful and measured in how I say this. I was like, it's a possibility, right? And that's true in a lot of these areas because we just don't have enough research to know. But the stakes are awfully high to be gambling on what we don't know, right? So that's why I want to raise that as a red flag.
But the danger, I feel like, related to that is the implication is that an individual with autism can't make a voluntary decision related to this.
And so this goes up to swim back upstream to your first point. That was interesting that you said, what if an individual who has autism and another condition, not depression, right? So why not depression? Because intuitively you knew there's something problematic about depression that's connected to suicidality. And in fact, I think it's the case legally in both the Netherlands and Belgium. Certainly it's the case in terms of their codes of practice, their professional codes of practice, that when a patient presents with depression, or sometimes mental illnesses in general, when a patient presents with intellectual disability, they're already called upon to exercise a sort of heightened care. So I'm not asking for anything more than that. And I think that you yourself sort of intuitively recognize that there are conditions under which that heightened care needs to apply. I simply want to suggest that we need to add autism to that list. Now the key thing here, though, and here I think we're in absolute agreement, I want to underscore this, is that the decision cannot be made simply on the basis of a person's diagnosis. That would be discrimination. The legal principles, as I understand them, that apply to assessment of decision-making capacity or decisional competence, as they call it in legal circles, insist that capacity has to be assessed always on a case-by-case contextual basis. So it's not, does this person have capacity in general? It's, does this person have capacity to make this particular decision in this particular situation? So for example, the illustration that often gets trotted out would be something like this. A woman who's 25 has the decision-making capacity to decide whether she wants to have sex with someone or not, unless she's drunk, right? Right. So you have to assess it on a case-by-case basis. So I agree with you wholeheartedly that it can't be made. The decision can't be made on the basis of the diagnosis. It has to be done case-by-case. But we've already acknowledged with depression and intellectual disability that there are some situations in which we have to be especially careful to watch for ways in which things might subtly go wrong. I also want to underscore this, that we talk about the right to EAS. The first thing I would want to stipulate is we're talking about a legal right. I wouldn't say it's a human right. But even the legal right is not an unqualified legal right. Right? There are some rights that you can only exercise under certain conditions. So in the U.S., for instance, you have to be a certain age to vote. There's a legal right to vote, but only if you're of a certain age. I think this is one of those kinds of rights, and I think those sorts of qualifications are built into both the Dutch and Belgian laws through the due care criteria. So it's not something that you have an absolute right to. It's something you have a right to granted that certain conditions have been met.
I just want to add one quick thing to what Josh was saying. The other corollary problem of denying legal competence to people who have autism or other disabilities is that in countries not in the United States yet, but in places like Belgium and the Netherlands, there's conversations about involuntary and non-voluntary euthanasia. And so once you've deemed an individual to not be competent to make decisions about his or her care, it's a much easier step to impose a protocol of involuntary or non-voluntary euthanasia on them. So it might actually put people with disabilities, especially cognitive disabilities, at graver risks to be looser with denying them the designation of being mentally competent to make legal decisions. So that's a serious risk. I mean, there's already discussions underway in the Netherlands and Belgium about the euthanizing of children.
Well, in fact,
infants.
it's happened.
Yeah, the Groningen Protocol, and you've got and persons with other cognitive disabilities. And in many instances, you say, well, we don't have to ask this person because they're not competent to make a decision. We're going to sort of paternalistically decide that it's time for them to go.
So would there be a guardian, though, in those circumstances that would be involved in that
It
decision?
varies from jurisdiction to jurisdiction, and it could be an ethics committee of a hospital. I mean, it's not always. My understanding is not always the case. I could be mistaken. That there's like a guardian ad litem appointed to represent the interests of the individual.
And so in the Netherlands, for example, if we talk about euthanizing young people, depending on the age of the person, the legal requirement for the involvement of the parents or guardians actually changes. So I think it's from 16 to 18 years. The parents and guardians need to be involved in the process, but they don't have to agree with it. So you have to let them know what's going on, but you don't have to have their approval. Younger than 16, different rules come into it. That's an interesting observation.
Okay, so I wanted to first of all thank you for a very thought-provoking, as Josh said, well-researched and very persuasive presentation. I thought it was very, very well done. I'm going to situate your comments in the general debate over the legality of assisted suicide and euthanasia. Try to show. I think what you're pointing to is a very dramatic challenge to the fundamental and I think most potent arguments in favor of the legalization of assisted suicide and euthanasia, as well as underscoring a lot of the prudential objections to legalizing, even among those who would in principle support the right to euthanasia or assisted suicide. So the most interesting example of this is the New York Task Force on Life and the Law from 1992. The Governor Mario Cuomo put together an interesting committee of experts in the early 1990s. All of whom were in principle in favor of legalizing assisted suicide. They didn't have any moral issues or ethical concerns. They were policy experts, healthcare experts, legal experts, and the like. And their job was to talk about how might this be operationalized in the state of New York? How could we legalize assisted suicide in the state of New York? And they concluded, to the surprise of many, that they couldn't in good faith recommend the legalization of assisted suicide in New York, not because they thought it was immoral, but because they thought the downstream consequences system-wide would be so adverse for vulnerable populations, the poor, the disabled, the elderly, members of stigmatized minorities. They thought that the injustices that were part of the healthcare delivery system already would be aggravated in such a dramatic fashion that even though they, for rich white people, it would be okay to have assisted suicide, the people who would be bearing the consequences and costs of that would be poor, minorities, disabled people, elderly people, through the forms of lethal forms of discrimination, risks of fraud, abuse, coercion, and duress, and the like. So let me just take what I gather to be the two most powerful arguments as a policy matter to legalize assisted suicide and euthanasia are, and there are lots of arguments that are made, but the most important arguments seem to be the arguments from autonomy. If you have the freedom to decide important matters, especially existential matters. And then secondly, and in some ways in tension with the first, arguments from compassion, which can take very paternalistic forms, which is, of course, the antithesis of autonomy. These are the arguments that I think move people to vote for legalizing assisted suicide. These are the kind of human stories, people making a decision on their own behalf before they lose the capacity to do that. People who are suffering intolerably, having their suffering ended by assisted suicide or euthanasia. I think. And those are strong arguments, and they're politically powerful arguments, and they're arguments that have prevailed recently in a string of successes in legalizing assisted suicide in the United States, in Colorado, and Washington, D.C., Hawaii, and elsewhere. Although it's still the case that only about 7 jurisdictions in the United States allow assisted suicide. No jurisdictions in the United States, including those that allow assisted suicide, allow euthanasia. which is to say the directed killing of an individual at his or her request, or perhaps not at their request, based on some judgment that their quality of life warrants that kind of lethal intervention. And I should say, in every jurisdiction in the United States, there is at least a common law right, and probably a right that rises to constitutional levels, to decline any kind of medical intervention, including, or to discontinue any kind of medical intervention, including life-sustaining measures. Those are things we have to kind of keep separate in our minds when we're talking. But in Belgium and the Netherlands, and this is typical in jurisdictions that move to a euthanasia protocol away from assisted suicide, where the person has to self-administer the lethal agent. Almost all deaths under this regime in Europe are direct killings by euthanasia. People will, and it makes a lot of sense that why would you have a regime where you have to self-administer a large quantity, usually orally, of barbiturates to take your own life versus an injection from a third party. So I think that the example that you flag here of persons with autism and other disabilities, and all the complexities involved with applying the due care criteria that you identify, raise real questions about autonomy. And I would join Josh. I don't want to say that people who don't have a medical decision-making authority because they have autism or even autism depression or something else, but the notion of that what happens when a person asks for assistance in dying or direct euthanasia is the sort of unencumbered assertion of the free self is not a fair or accurate clinical picture of what we're talking about. The reality of the clinical context is much more complicated than that. And so I think it's an ill fit to apply black and white legal categories of competence or not to what are much more layered human questions about, well, how can we help this person? What does actual care require for an individual who presents in this way? So the compromises to one's full flourishing of autonomy that you've identified here are really important for us to think about, the two most potent arguments in favor of. And then especially with the compassion point. The risk that I worry about is a different kind of discrimination that Josh is worried about. The thing that worries me most in this space, especially with euthanasia, is able-bodied people making decisions for people who are suffering, and they're not able to enter into that person's experience. And they make decisions about, well, if I were like that, I sure wouldn't want to keep on living. And that puts a very strong weight on the scales in deciding what you're going to do in those scenarios. And so compassion can quickly give way to really quality of life determinations that are discriminatory and don't take account of the full lives of these men and women. The prudential arguments against legalizing assisted suicide, and this actually in some ways avoids the problem of you have a legally recognized right, who are you not going to let exercise it because of different decisions you make about competence and so on. The New York Task Force on Life and the Law and the President's Council on Bioethics and others have just, in many state jurisdictions, have decided not to legalize assisted suicide because they don't want to have to deal with the complexities and the dangers of those kinds of decisions. That the benefits for those populations, for the narrow band of the population who arguably is operating at the height of their autonomy and are suffering intolerably or terminally ill or whatever, the benefits to that narrow sliver do not justify the enormous risks to these vulnerable populations that I mentioned a moment ago. And so in these risks take the form, as I said, lethal forms of discrimination, deadly risks of fraud, abuse, coercion, mistake, corrosion of the doctor-patient relationship. That, I think, is pointed up in your conversation about that particular doctor, Teenpont, who seems to be very ready to give out autism diagnoses for people that want them. And if you're coming to a doctor and you're suffering emotionally and you have an autism diagnosis and perhaps depression as well, there's going to be it's going to be a strange dynamic when you go to see Dr. Teenpont, to receive healthcare in that situation. We've seen in jurisdictions where they've legalized assisted suicide, Oregon, Washington, and others, there's a dramatic drop in the incentives to diagnose and treat mental illness in situations where people present wanting to end their own lives. Same thing with pain management. The suicide rate goes up. In Oregon, the suicide rate is much higher than it is in many other jurisdictions. That's true in those jurisdictions that legalize assisted suicide. And it seems to me that these are sort of consequences for the practice of medicine that happen when you introduce euthanasia into the equation. So people who present with autism and depression, the toolbox has got euthanasia right in the middle of it. I remember a Dutch doctor who was talking about how he deals with certain kinds of bowel obstructions in certain sorts of patients, they say, I usually use euthanasia to deal with that, which is not a therapy, of course. I mean, eliminating the patient is not a way of eliminating a pathology. So, so let me just say a couple words briefly about how what you described relates to the United States. In the United States, this is not an issue yet, precisely as it's emerged in Belgium and in the Netherlands, because the criteria for eligibility for assisted suicide in the United States is terminal illness. There's no requirement of suffering, whereas unbearable suffering from a medically futile condition is an essential feature of what you're describing, which opens the door to all kinds of psychiatric diagnoses and other even non-medical diagnoses. Persons tired of life is something I've heard invoked in certain European jurisdictions. But in this case, you have to be terminally ill, which is not a great, as legal standards go, not a great standard. It's very hard to predict. I mean, in fact, 80% of terminal ill diagnoses, meaning you're going to pass away within 6 months, turn out not to be right. So it's not a stable line exactly for a legal regime. But these things don't happen in the United States yet. What happens, though, there are some worries, though, and the evidence. Oregon is the oldest law regarding assisted suicide. We have seen some interesting related problems in Oregon that connect to what you're talking about. We don't have the same problem because you show up, you have an autism diagnosis or a depression diagnosis, and you say, like, in my life, if you're not terminally ill, you're not eligible. Now, there are real issues with data collection in these states. We don't quite know how these laws are being administered because the data collection is purely voluntary. There are no audits, and that's true across all jurisdictions. Every law in the United States is modeled on the Oregon law. In Oregon, there's no requirement of there's no automatic requirement for psychiatric evaluation. Only if you present symptoms that suggest that you have compromised legal competence, and that's a very, very high bar. And this is a problem because if you look at the percentage of the number that I've seen, people with diagnosable psychiatric illnesses who have suicidal ideation is something like 95%, 66% for people with depression. And if that's true, you compare those numbers, even the lower numbers, 65%, 66%, the number of people who have suicidal ideation, it's only 3.6% of cases all time in Oregon of people who receive psychiatric evaluations who have presented for seeking assisted suicide. That's a dramatic problem, it seems to me. Same thing for pain management. There's no requirement in Oregon law that anyone be present when the person self-administered the law or self-administered the lethal dose, and there's no requirement to evaluate competence or voluntariness at the time of the self-administration of the drug, which is seriously problematic if you're worried about fraud, abuse, coercion, and so forth. There are no limits on doctor shopping and in the same way, and there's no requirement to notify or interview kin or anyone else to see if you can detect problems with coercion and duress among family members. And then the last point is some jurisdictions have made exceptions to this, but it seems like there are a lot of holes in it. The way healthcare is financed in the United States, this may not be a problem in Belgium or the Netherlands, there is a real problem when it's so much cheaper to pursue assisted suicide than certain kinds of treatments. And again, we're talking about terminally ill patients. And there have been multiple instances in which insurance companies have sent letters to patients saying, we won't pay for this palliative chemotherapy, but we will pay for assisted suicide. So anyway, so that's just recently, there's a brief comparison between what you're describing here, but overall, I think what you flagged is a kind of very serious case for thinking about the most potent arguments for assisted suicide as well as the prudential arguments against it. And again, my remarks bracket the question of whether assisted suicide is wrong in itself or right.
Right. Yeah. So just maybe a couple of quick words in response to that, then we'll see if we have some questions. Yeah. So I think that you're right that what I've done with the first two of the three due care criteria really is, in a sense, an attempt to address arguments from autonomy. Although I hadn't conceptualized it in that way, I think that you're right, and I also agree that the arguments for autonomy and compassion really do seem to be the two primary arguments that are presented by advocates of this practice. In fact, in my email correspondence with Dr. Timpon, she voiced her sentiment that these people are suffering and she's trying to help them. So she sees herself as being engaged in a compassionate activity. By the way, some of you might recognize her name because she's now being brought to trial. Charges are being brought against her in Belgium for a case which has become infamous, the Tina Mace case, which is a woman who was diagnosed with autism and then died by euthanasia. and her family is contesting it. This would be the first prosecution in Belgium, I believe. There's one other case where they sent it to the prosecutor, but it didn't go to court. So I think it's over 10,000 deaths by euthanasia now. This would be the first one that would be prosecuted if it goes through, which is sort of extraordinary if you talk about it.
Has it moved to prosecution? I know it was investigation, but I know it was actual prosecution.
My understanding is that it's gone to the legal, from the reviews to the legal side. But with respect to the argument about compassion, I think it's very important that we focus on that for a moment, because the suffering is real, right? And compassion is a good. We don't want to deny compassionate responses to suffering. My question would be whether this is the right compassionate response. As the father of 2 children on the spectrum, it's heartbreaking for me, and I think you can sympathize to understand that some people who have autism feel their lives as a burden that they would rather be relieved of rather than something that they enjoy and they're grateful for. And I think we have to work very hard to change that. But I don't think the response to it is to end their lives. I think it's to increase access to services, is to develop better services. It's to become much more adept individually and socially at including people on the spectrum in all dimensions of life and society. And not just including them, but learning to value them for who they are. So compassion really is an important point in this discussion, and I appreciate the fact that you gave me a chance to underscore that a little bit.
Can I ask one quick question before we open it up to the judge? This is maybe more for Josh. Do we think that these autism diagnoses in the Netherlands and Belgium are pretextual because they're diagnostically easy to assign, or do we think that this is the targeting, or what? Not targeting is the right way. That might be too provocative a word, but is it? Are we dealing with, because you're talking about people who show up and have never been diagnosed with autism before, and then they get one, and it reminds me a little bit of saying we need to get you a diagnosis so we can get you services.
Right.
But in this case, it's we need to get a diagnosis so we can get euthanized. What do we? Is there any? What do you think?
I mean, I can tell you that there are people who are at the heart of this discussion who have suspected that that's what's happening. I can also, I believe it's the case. Let me verify this. I believe it's the case that's one of the things that Tina Mace's family is alleging Dr. Diehl did, that she didn't have autism. They gave her this diagnosis.
Are they going through like a full evaluation to get the diagnosis, or are they just saying, "Oh, you meet this criteria because I talked to you in this," and then you meet?
So, and I have no answer to that.
Because that would be the difference right there.
Yeah, the records don't tell us.
It would have to be an independent evaluation by somebody who's not making the decision for it to be a valid diagnosis.
So I think we have time maybe for one question from the audience if there's a question.
So if in Belgium or Holland, if they change the criteria, you made it clear, like a red line, that we're not going to use autism as a criteria for the suffering or a fetal condition. That's not it. And we're worried that your admonition that they just be more careful with folks with autism is in reality might not work very well compared to a clear line. And so maybe that way, somebody with autism could still, if they had a terminal illness like cancer, could still have their right to the assisted suicide. And yet it would still be protected with folks with autism. And yet I would think that you can make an argument that it's pro-autism rights too, because you're not saying that they've got this poor, pitiful condition that's hopeless.
And in fact, it's interesting that many disability rights activists are opposed to these practices because they see on a daily basis the devaluing of human life with disability. They experience it oftentimes, especially in the context of receiving medical services, and they think this is just an escalation of a very long historical practice of devaluing their lives. And I think we're seeing that particularly from the autism community as well. My concern with making autism sort of a straight red line, that we're just not going to allow autism to be a diagnosis that could grant you access to this, would be the concern that Joshua has, that then it potentially becomes a form of discrimination. And I'll just go on the record as saying I don't think anybody should be doing this. But as a legal matter, it becomes a form of discrimination. And in fact, my understanding of the legal requirements in both
Belgium and the Netherlands is that, in fact, you have to assess capacity on a functional basis, on an individual case-by-case basis. So in a sense, you might actually be going against the law that's already in place in those jurisdictions if you instituted some kind of, automatic red line like this.
Well,
Thank you. Thank you.
Thank you all for